Good evening. On behalf of Naari Division of Jagsonpal Pharma, we welcome you all to the webinar today. October, being World Menopause Month, will with the theme of MHT in 2024, we celebrate with today's webinar focused on discussing latest in menopausal hormone therapy. The expert with us today will help address the key controversies around MHT. Before we begin the session today, there is an announcement. To make this webinar interactive, prizes will be awarded to the top 3 questions asked during the webinar. Please keep your queries ready to ask at the end of the session, and 3 winners will be announced. We welcome and express our gratitude to our expert today, Dr. Sunila Khandelwal. Dr. Sunila Khandelwal, ma'am, is Director, Midlife Women Healthcare and Menopause Center, Fortis Escorts Hospital, Jaipur. She is member board of Trustee and past Treasurer, Secretary General CAMS of International Menopause Society, apart from holding the post of past President, Indian Menopause Society. She has been the ex-medical superintendent, professor and head at Obs Gyn department at SMS Medical College, Jaipur. Dr. Sunila Khandelwal has held various prestigious posts and won so many national and international awards. Her interest in research and academics is seen as she has been involved in creating modules for GPs and undergraduates on midlife women's health curriculum and management of menopause. She has inducted CIMP exam for Indian menopause practitioners. She is the founder editor of the Journal of Midlife Health of Indian Menopause Society and has published many research papers in reputed journals. We welcome and thank you, ma'am, for your commitment and support. At the end of the session, Dr. Sunila Khandelwal will be available to interact and answer any questions and clear any queries of all the delegates. We encourage you to interact with her. Please keep your questions ready or type in the chat box. And during the Q&A session, if you wish to ask your question directly, then your audio will be enabled. Remember, 3 best questions will be awarded a prize. Welcome, ma'am, and over to you to begin the session.
Thank you, Deepika. I'm really honored to have this session today, which is on World Menopause Month and World Menopause Day, falling on 16th October, and October is the whole month, World Menopause Month. As per WHO, in collaboration with International Menopause Society, have designated this whole month as World Menopause Month, and we are happy to celebrate this month on the theme-based topic of this year, that is 2004, Menopause and MHT in 2024. I would be addressing the key controversies around this topic because we all know menopausal healthcare is a challenge, and the celebration needs the clearing of the controversies, clearing the doubts in our healthcare professionals, and encouraging women to seek the advices from our practitioners in a right direction, right time, and for improving the quality of life. Because the population aging is a major challenge of 21st century, and there is a paradigm shift from treatment to prevention, and there is a necessity of optimizing menopausal health. I am happy that globally and specifically Indian Menopause Society has already started in every area since last 26, 27 years for the efforts across the country, and of course, working in International Menopause Society platform. I see the global, there is an effect coming related to prevention strategies which are being taken care of by the practitioners across the globe. Because it's a rapidly expanding field of medical practice and scientific investigations, and we need to prevent the NCDs, which are the silent killers, and of which 18 million women, they do suffer from NCDs. So there is a recent focus which is on empowering women to proactively manage their distressing menopause symptoms to promote a positive view of menopause as a natural stage in a woman's life, an opportunity to reevaluate and address the current and future health concerns. More recently, there has been a growing recognition that these symptoms can have a profound impact on performance in the workplace, leading to reduced individual and corporate productivity, loss of efficiency, and even loss of employment. So it's a very serious issue which has to be taken care of because it impacts significantly on individuals' physical, mental, and cognitive health, as well as their personal and professional services. So, and there are many studies which have shown different types of menopausal symptoms, how they affect personal, social, and professional quality of life. But for Asian women, like in Indian women, the physical symptoms such as the body aches, joint pains, as well as the psychological symptoms are recognized to be more prevalent than the vasomotor symptoms. And around more than 65% of the women, they do suffer from joint and muscular discomfort, according to a recent systemic review and meta-analysis. But there has been a considerable controversy regarding what constitutes a genuine menopause symptoms and which has resulted in inconsistency as to what outcomes and the best measurement should be assessed in clinical trials. And this has led to the recent development of the COMA initiative, and I'm happy to say that I was the part of this project, which was done across the globe, and this is published in NAM's Journal of Menopause. And the recommended measurements instruments for GUSM and also for VMS have been sorted out, and the consortium has been passed. So there is an unmet need for easy access to evidence-based information, safe and effective treatment options for those needing treatment. So the healthcare professionals working, especially in menopausal healthcare, has a duty to provide a supportive, informative environment wherein women can freely discuss the menopause as it affects them individually and express their concerns and priorities and receive personalized care to optimize their health and well-being in second half of their life. With this background, the importance of menopausal healthcare, we can just recollect what are the milestones. Initially in 1700, it was noticed that reproductive failure, these are called as anti-aging silver bullets. So 1700 recognition of reproductive failure, then negative conditions started associated with disease. In 1929, estrogen was identified, and in 75 there was cancer scare, and the 1978 the International Menopause Society was launched, and 1989 NAMS was started, and Indian Menopause Society was launched in 95, but whatever is being done in favor of the menopausal hormone therapy for giving the women the right dose, right time, and right prescription is still the WHI studies was, they were really, there was a big attack of WHI, and but almost, and now almost after more than 20 years after first WHI report, the pendulum has swung back in favor of MHT, and for most symptomatic newly menopausal women. So not only has MHT has been clearly established as most effective treatment for VMS, it ameliorates GUSM, and also it's a cardioprotective. And the concurrent analysis also concluded that within 10 years, if given, has less 30% lower mortality. So now we are more confident with, and the doubts have been cleared, which was created the cloud of WHI effect. So what has been changing? The knowledge and physiology, we are more understanding this. Health system is changing. Women's attitude and awareness is changing with the efforts of all national and global organizations. But still there was a decline in appeal of MHT, and the alteration in the MHT uses were there, development of pharmaceutical alternatives were there, food supplements started and public health policy was being made. Consequently, with the decline of MHT, we can see that many of the women were ignored and was having a significant impact of untreated menopausal symptoms on quality of life. So by accumulation of the facts now, over after 50 years, we are getting close to the truth, because most of the time in our world, truth is just opinion. But still, menopause and MHT continues to be the topics of considerable controversy and debate to the detriment of many women and society as a whole. But we have to accept that in this aging population globally, in 2025, more than 1 billion women globally will be in perimenopausal and postmenopausal age group. Where the MHT should not be considered as anti-aging strategy, but it highlights that the need of the women is to receive the trusted information about why and for what purpose MHT can or cannot be provided. So the straw system, I think everyone, those who have joined this webinar, they must be aware about the straw system. And I'm not going into detail of this because it includes the biomarkers and also the symptoms, but I would focus on our Indian Uncles areas staging. Our own past president has given this staging, and that was really good and very easy to understand, where stage 1, 2A, 2B, and 3 is there. And everyone knows about this staging, and we have to prevent, treat, and palliate in third stage. So knowing these stages, knowing the importance, knowing that the duration of each stage, knowing the long-term complications, we need to have a balanced narrative of new menopausal momentum and providing a contemporary review of menopause and prescribing principles. In this view, I must congratulate the team of International Menopause Society who has brought this Menopause MHT in 2024. And it is this white paper is being released just on this October 1, and where the 5 Ws were discussed. And I'm going to focus my lecture on this, which this provides easy access advice regarding the several recent controversial MHT prescribing issues in healthcare and media spotlights. So who is MHT for? What types of doses of MHT? When should be started or stopped? Why MHT is important? Where MHT can be assessed? These are the 5 Ws I will be focusing on. So who is? Usual indication, VBA, GCM, VMS. We all know. Osteoprevention, first line option. Then asymptomatic women, MHT is primarily indicated for symptomatic women. MHT should not be regarded as an elixir of youth. MHT is not currently indicated for primary prevention of CVD or dementia in women at usual age of menopause, but it is important in preventive therapy for women with primary ovarian insufficiency, early menopause, and even in asymptomatic women. In high-risk women, we have to have prayerful counseling of big benefits and risk balance, and as well as with any other medication if they are taking. And definition of acceptable risk will vary. The personalization of the prescribed required, and there has to be ongoing development of medical eligibility criteria, which is useful, like we have development every now and then in the field of contraception. So the doses and type of MHT, typically what we prescribe depends on patient preference, uterus presence or absence, contraceptive needs, symptoms, type and severity, and comorbidities. So various algorithms have been published as toolkits which clearly guide HCPs, and International Menopause Society has already initiated an IMPART program, and beautiful slides, easy slides, can be accessible by every one of you, where we can see that the individual prescription is for clear indication. It can be initiated for menopausal symptoms, and osteoporosis prevention should not be recommended without a clear indication for its use. Duration is consistent with the goals and visual benefits, risk and profile, and assess actually annually. Type and route depend on the preference, safety, and drug coverage, as I said, and doses should be titrated according to the symptoms. But of course, the decision is impacted by personal risk factors, including age, time since last LMP, health risk factors like VT, stroke, heart disease, and breast cancer. So we have in place and evidences and recommendations related to the prescription in every area and which type of hormone therapy, which type of menopausal hormone therapy have to be given, and approved indication we have discussed already. But of course, for VMS, combined MHT estrogen therapy in case of alone in case of patients who had surgical menopause, vaginal atrophy, local estrogen. If there is overactive bladder, vaginal estrogen, recurrent urinary infection, again vaginal estrogen. So these common indication and evidences are there in place, but we have to remind ourselves about the contraindications, known and suspected breast carcinoma, active cardiovascular disease, active liver disease, active VT, pregnancy or unexplained vaginal bleeding. And if we are prescribing non-oral, if we are prescribed, the transdermal can be used in cases of those who are smokers, because these are all high-risk cases and they need transdermal. Smoking, diabetes, hypertension, triglyceridemia, hypertriglyceridemia, migraine without aura, but there are the strict contraindication, chronic cardiovascular disease, dementia. There are potential contraindications with dementia and migraine. So by and large, we have to individualize as looking into the contraindication, and the route has to be identified. This is a beautiful algorithm which says that MHT can be given and which dose, which type of MHT, and the different types of female where there is a uterus intact. We can have combined transdermal patches, transdermal gel or LNG IUCs, or oral estrogen plus oral progesterone, which is very common now, and I'm going to tell you about the newer one. Tibolone, estrogen plus SERM, and also if the patient has hysterectomy, means there is no uterus, then of course we can have only oral estrogen, and Tibolone, as we know, it's a gonadomimetic, so can be the first line of treatment. The second line could be where the persistent symptoms are there. So, but in perimenopausal women, we have to review the contraindications. Estrogen, progesterone as contraception, we can use, or oral estrogen with LNG IUS, or continuous estrogen and cyclical progesterone. So it depends which type of, what is the personal choice, what is the personal history, what types of medical indications or contraindications are there. One has to manage menopause by identifying and treating the main issues, whether the urogenital issues are there, or VMS are there, or sexual dysfunction is there, or if there are no concerns, then we have to, there is no need, rather we can just advise lifestyle modification, but we have to exclude the common causes of contraindications, and also we have to have in our armamentarium the non-hormonal treatment, though in women, those who are not ready for MHT, or in which we cannot prescribe MHT. There are the doses, and I will not go into detail. I think we all know what to prescribe, when to prescribe, and in what doses. But there are some preparations which are still not available now in India. But yes, most of the time we can manage menopausal symptoms. We have different combinations and all the drugs available in our armamentarium. So coming to the what type of estrogen, I would say we need to have the route of delivery could be oral versus a non-oral, and we need to know the VT risk, and then only we can prescribe transdermal. But if there is a healthy woman at usual age of menopause can have oral MHT if they prefer, if they cannot absorb or allergic to transdermal estrogen. So we have all the preparations available. The progesterone primary indication is to, we all know that to prevent the endometrial hyperplasia. And that's the reason we don't prescribe progesterone where the uterus is not there. So we are not worried about that. And most of them, mostly the tolerance and safety should be considered in prescribing. And there are body identical progesterone and body similar progesterones like progesterone, which have less adverse impact on cardiometabolic and breast risk markers than androgenic progesterone. So we have in our we have all types of combination available. And coming to the dose, I think the minimum fully effective dose has to be prescribed to achieve the maximum benefits. And if the dose of estrogen is increased in non-fixed dose of MHT formulation, the dose of progesterone should also be increased. That is very, very important. It's not you just increase the dose of estrogen to get the results and you are not increasing progesterone. So it has to be balanced for endometrial protection. However, we have other options available, including the vaginal progesterone, intrauterine LNG system, oral tissue selective estrogen complex like TSEC or CE or bezidoxifene. And the custom compounded bioidentical hormone therapy is not recommended ideally because of the concerns of the rigorous safety and efficacy testing. And but if they are tested and efficacy is proved and they are safe, we can prescribe. So I congratulate Jagsonpal, the Pharma Jagsonpal, who's just brought this new product that is MAMUP, which is the first and only FDA-approved combination of bioidentical estradiol and bioidentical progesterone available in India, provided in single oral capsule approved by US FDA as Bijuva, and provides hormones that are chemically and biologically identical to the woman's own. Each capsule is having 1 milligram estradiol and 100 milligram of progesterone, which is micronized progesterone. And this combination is unique because it mimics the body natural hormones and simplify the treatment regime and enhancing the patient compliance and the outcome. It is it can be ideal for women with PMS due to its unique combination, and of course it stands out with in comparison to other MHTs due to the unique efficacy of oral micronized progesterone. And this easy use improves the patient adherence, which is a very common problem in menopausal females. Once we prescribe, they just get the results within 3 months, and once they are okay, they will just stop and they will say why to take. But single capsule, I think the adherence will be much more we expect. And the convenience once daily dose in a single capsule is a good protocol to be used in these particular women. So congratulations to Team Jagsonpal. And once we prescribe the MHT, how to monitor? Routinely, we don't do hormonal profiles to initiate or monitor, but they can be, the hormonal profiles are useful whenever there is inadequate symptom relief after 12 weeks of commencing or switching MHT, if there is persistent adverse effects after 12 weeks of commencing and switching MHT, use of MHT in POI, early menopause, especially if efficacy issues are there, adverse effects are there, or concerns about osteopenia or osteoporosis. So these are the 3 common areas where we would like to do hormonal profiles for monitoring. Once prescribed, we have to review the treatment for MHTs within 6 to 8 weeks, whether she has relieved with the symptoms or she has side effects. If there are side effects and no relief, then change the dose or the therapy. If there is relief, then next follow-up will be after 6 months. If there is no symptom relief and again there is side effect, then again you have to change the dose or the therapy. But if there is relief, then the next will be 6 to 12 months review, and we can review the efficacy, side effects, and the risk after 1 year. But if there is recurrence of symptoms, then definitely she needs a specialist referral. So 6 to 8 weeks, 6 months, 6 to 12 weeks, and then if needed, a specialist referral. A word about testosterone. There is a lot of doubt about the role of androgen, and ideally there has to be a biopsychosocial approach if there is sexual difficulty. And for the diagnosis of HSDD is hypoactive sexual desire disorder or distressing low libido. And the testosterone preparations remains still off license across the world for women for most of the countries, but require down titration for male preparations such as gel, and ideally 1/10 of the male dose can be prescribed. I'm happy that I was a part of the global consensus position statement on the use of testosterone therapy in women, which was released by International Menopause Society, and it is available on the website. And where it says that the premenopausal oophorectomy is whenever if there is free decrease in the free androgen index levels by 50%, we can prescribe, or if there is decreased libido in spite of adequate estrogen replacement, then again we can prescribe. And of course, in HSD patients with or without concurrent estrogen therapy, we can prescribe because it has a beneficial effect on sexual dysfunction. And there is level 1 grade A indication for short-term transdermal testosterone therapy. And there is expert opinion is that the caution is recommended, especially for testosterone use in women with hormone-sensitive breast cancer survivor. It was released in Chicago position statement. When now next one is, when should the MHT should be started and installed? Very common questions in the minds of HCPs, healthcare providers. So I will say the two areas are most important. One is POI or early menopause, where the MHT or COC should be commenced as early as possible following the diagnosis, because the early institution restores the quality of life and reduces the risk of long-term health risks like osteoporosis, CVD, or dementia. And it should be continuous at least till the age of menopause. We know in India, the average age of menopause is 46.7 years. So if the lady has premature menopause or if she has POI, then maybe at 40 years or maybe at 35 years, then till the age of natural menopause, we should be given. But of course, the benefit risk assessment should be done. And it is also indicated in women with, in late perimenopause, where there are symptoms. And depending on the contraceptive need, we have to choose the MHT, and we have to consider the VT risk also. So when should be started? The older postmenopausal women, less than 60 years of age. After 60 years, usually not recommended due to potentially increased risk of VT with oral MHT and stroke. And use of MHT to treat and prevent the osteoporosis in women in more than 60 years is not recommended as first-line option. However, personalized prescribing is based on the benefits risk assessment, and especially in women with persistent vasomotor symptom. And of course, in VBA and GCM, we can prescribe topical estrogen and of any age group till any age limit. That is not contraindicated. When should be stopped? Arbitrary limits, 5 years should not be placed on the duration. A personalized approach should be employed, empowering women to make an evidence-based individual decision. And there is an ongoing use of MHT rather than initiation of MHT in women with less than 60 years may be associated with more favorable risk-benefit profile for CVT and VT events. So we now know the primary indications. VBS, VVA, VMS, improve cardiovascular profile and cardiovascular health and reduce the risk of osteoporosis. However, the risk has to be, breast cancer risk is the most important thing in the minds of the healthcare providers. So we must understand that the risk of breast cancer is associated with estrogen, with synthetic progesterone, not with natural progesterone, and it depends on the duration of use. Risk may be lower with micronized progesterone or dihydrogesterone and versus than synthetic progesterone. And the risk of breast cancer is attributable to MHT is small, and the risk decreases progressively after MHT is stopped. So we have to have an individualized screening before prescribing, and the screening related to personal history, family history, physical examination, lifestyle choices, genetics, and other risk factors. The goal of evaluation of taking all these history and evaluation is to promote healthy lifestyle, to address symptoms, to screen for cancer, to screen for CVD or other age-related diseases like diabetes. But the most important part is counseling of patient. That is very important. We have to explain the indication, discuss the benefits, discuss risks, discuss the side effects, discuss the contraception if applicable, and discuss the alternatives too if she is not ready or we cannot prescribe. So appropriate type of MHT and its mode of delivery should be individualized. We have everything available, and it is the clinician who will decide that for which indication you are giving, and we have everything available in our armamentarium. Of course, if their dense breasts are there, you have to focus that low dose of estrogen have to be given, and tibolone can be given safely, and estrogen and SERMs can be given. That is very, very important. Rest we all know. Now, there are women with special issues like Turner syndrome, fibroids, obesity, hypertension, BRCA gene mutations, migraine, endometriosis, and prior VT. So we have to individualize, like if the patient has fibroids, not necessarily contraindicated for MHT use, we can in low dose can be given. However, if she is obese, we have to give transdermal estrogen, and especially in women with endometriosis, very common that if the oophorectomy for severe endometriosis is done already, then combine MHT to avoid reactivation and endometrial carcinoma. So this is the only indication of surgical menopause where we have to give combined MHT to avoid the reactivation. The IMS toolkit at International Working and International Platform, I must I advise you to visit the website, see the toolkit, see the key messages very clearly given, and international guidelines have validated and provided recommendation for safe use of hormone therapy. And Indian Menopause Society, of course, has given the clinical practice guidelines, and recently again they are updated also. So the MHT is the gold standard for the treatment of severe menopausal symptom, urogenital atrophy, osteoporosis, within 10 years of menopause and less than 60 years of age. Hormone therapy should be offered to women with POI and early menopause, and it can be recommended until the age of natural menopause. But the principle is right woman, right age, right HT, right dose, and right route. I will advocate all of you, those who have joined this webinar, to go to the international website and take this module. It is a very good program, practitioner training for healthcare professionals. There are 2 levels, level 1 and level 2. And upon completion, the participant, you will receive a certificate and 1-year complimentary entry-level associate membership you can enjoy. So there is online Impart Masterclass series in India already floated. We have a statement, the last position statement in 2020, again from NAMS, that is the personalization with shared decision-making remains the key. I think we have still, for the young attendees, I would say there are areas of research for you. We have research needed for thrombotic risk. And January 2022, we have published a paper where I think Dr. Meeta and myself has released this paper on menopause hormone therapy, migraines, and thromboembolism, where it is advocated that the oral versus transdermal therapies are needed for patients with VT. So we need to have more clinical trial data. And of course, we have to have more data related to POI, related to the VMS and heart disease, related to the SERMs regimes and also T-sec therapies. So for last, I think half an hour, we're discussing about MHT. But some of you must be thinking whether the menopause is being over-medicalized, whether really, no, it's not the case. Although we advise the lifestyle, diet, and exercise, but because of the distressing menopause-associated symptoms, we have to identify and address, and we have to treat with MHT or medicinal alternatives. There has to be provision for routine menopause check. And of course, the IMS India and IMS International has given us an easy, equitable access of evidence-based knowledge and healthcare, empowering our women to make fully informed midlife health choices. We have non-hormonal options in our armamentarium. I'll not go into detail. SSRI, SNRIs, and recently there is a newer product of neurokinin receptor antagonist, which has widened the therapeutic choices. The therapeutic areas is still which has unmet need. So we have to understand that of more than 50%, they are suffering in silence in BBS, GSM. So please do prescribe MHT and just decrease their suffering. For PI women, again, it's a serious problem across the globe. More than 4% women, they are suffering. So it has to be tackled. And of course, the perimenopausal fluctuation, make the life hell of a woman. So we have to listen and ask, assess, and treat, and give the comfort. And iatrogenic menopause day in and day out is increasing. We have to be sensitive for this. However, unfortunately, in India, still we have a limited access to MHT, limited healthcare professionals, although across the country we have menopausal healthcare practitioners who are expert in the prescribing, but it's still there is misinformation and disinformation in social and other medias, which is creating a confusion and disempowerment of women about the menopause and MHT. So we expect that more and more government initiatives and HCPs should take charge and inform the women, and appropriate menopause advice and menopausal management has to be given to these women by improving the efficiency and productivity in workplace, and also for reduction of societal healthcare burden. This is just a summary of general management guidelines. All the organization, I've tried to put this slide and toto that related to indication, related to risk, related to initiation, and related to duration. All organizations have come together and given this final dictum of prescribing MHT. We have holistic management. We do believe in an Indian scenario specifically. We have complementary therapies. So we should adopt a biopsychosocial approach, which is the key milestone in a woman's life. And we have to prevent this, decrease in quality of life with increasing menopausal women across the country. And I'm glad we have CPG guidelines on our table to give us the right directions for prescribing. But I must advocate each one of you, those who are not having a still menopause clinic, there is a need related to demographic dynamics. There is increased patient pool, and there is menopause strikes early in India, and also it is affecting the socioeconomic status. So please do go ahead, and there is a lot of opportunity in India of menopausal health clinic. So establish your own clinic and do well women screening, because it should offer, and ideally it's a whether you are working in private or government or academic or hospital, we should have a menopause clinic in place which offers coordinated, comprehensive, interdisciplinary care of women in midlife with basic philosophy to provide mature women care in one-stop shop, including education about medical issues, options for treatment or alternatives. So, the ultimate goal is that we have to have planned, cost-effective system in place to promote healthy, active, graceful aging. Thank you so much and wish you good luck for your all future endeavors in this field, and also happy World Menopause Month. May you empower yourself and the women across you to deal with menopause ailments and improve the quality of life and to give a better world for tomorrow. Thank you so much.
Thank you so much, Dr. Sunila Khandelwal, ma'am. This was really very, very much enlightening. And now I invite our team member, Ms. Bhavika Sharma. She's our product team member and she would like to talk about MEMUP, the latest MHT which has been launched by Jagsonpal Pharma. Over to you, Bhavika.
Thank you, Sunila ma'am, for such an informative session. It was really helpful. So, manage vasomotor symptom presenting first time in India. MEMA, once daily combination therapy of progesterone and estrogen. Doctor, progesterone and estrogen in MEMA help her move beyond the disruptive impact of hot flashes and proven to reduce the frequency of severity of moderate to severe VMS. Provide extraordinary care with MEMA as MEMA addresses multiple aspects as it provides relief from moderate to severe VMS and reduces symptoms by 76%, and also provide endometrial protection as it mitigates the potential risk associated with estrogen therapy alone. A balance of bioidentical estrogen and bioidentical progesterone is indicated for healthy menopausal women in having an age bracket of 40 to 65 years old and are having intact uterus. The study also includes the healthy menopausal women seeking relief from VMS along with more than 12 months of amenorrhea, spontaneous amenorrhea, and more than 6 weeks of bilateral oophorectomy. MEMUP is a soft gel capsule which is to be taken in evening with food, and clinical response should be reviewed periodically at the interval of 3 to 6 months. That's all. Thank you.
Thank you so much, Bhavika. The cost of each tablet, that has been one of the questions in our Q&A box, is
22 rupees per tablet. It is a strip of 10
soft gels
per capsule, and it is a strip of 10 capsules. So the cost of strip is 220 rupees MRP.
Thank you. So for any brand related queries, you can contact at this email that has been mentioned. The phone number has been mentioned. That's deepika@jagsonpal.com. And the phone number is 9810269907. So please divert all your queries related to the brand for Naari brand, that is the Jagsonpal brand MEMUP. You can direct them here. Now we have the time for the question answer session. Those who would like to ask the question, you may please raise your hand. Otherwise, we will just first of all start from the Q&A. So the Q&A box. The first question that was asked by Dr. Shaili Agrawal was that of the MRP, what the MRP is and whether it is freely available throughout. So the medical representatives are making an effort to make it available all across all the retailers. Definitely it is available at all your counters, which are the major counters near your clinics. So be rest assured that you will find MEMUP. It's easily available. There are other questions which have been put up by the same doctor. Any particular prerequisite or specific examination or investigation required before prescribing MEMUP? So over to you, Dr. Sunila ma'am.
Thank you for asking this question. For any MHT, we have to have a pre-MHT complete screening. So nothing other than a routine screening, which is used for MHT prescription. Extra, nothing is needed, but only thing is that we have to know that you are prescribing with the women, those who are having uterus intact. And also, so you have to have a baseline endometrial lining thickness. You have to have baseline all routine investigations plus a mammogram if it is indicated. And of course, if you are prescribing for vasomotor symptoms, nothing, no hormonal profile is needed. The symptomatic women can be prescribed. But if you are prescribing for osteoporosis or primary management, and then you can have a baseline. So nothing is specific, but the most important thing I would again focus that you need to have a basic ultrasound for endometrial thickness because you are prescribing a combined MHT.
Thank you, ma'am. Another question by the same Dr. Shaili Agarwal. MEMUP is a combined drug, estrogen plus progesterone. Which progesterone it contains? So ma'am has been talking about it. It is natural micronized progesterone. Correct, ma'am?
Yes. Next question.
Next question is Dr. Shaila Jamal. She's asking about testosterone gel. Is it available?
In India, we don't have, but we have oral testosterone available, and we can give this for 3 months and see the effect. And it has to be given in small doses also, and with close monitoring.
Another question that she has asked is Indian data on MHT and cancer, especially breast cancer.
There are not very, combined data, but I'm sure we are going to publish again. And the overall data gives us a indication that it is safe for prescribing within total for 5 years and within 10 years and less than 60 years of age, as I have shown in the slides.
Dr. Sanjana Bhatt asks what all investigations required before MHT is started with intact uterus in rural settings with limited resources.
Yeah, I like this question because yes, we are working with limited facilities. So I would say routine blood examination, like, then blood sugar, and you can have, if you have taken the history, if you find any medical problem, then it has to be related to that medical problem. Otherwise, in a healthy woman without any medical problem, routine investigations are needed, nothing very specific, but with the intact uterus, again, ultrasound is, and I think ultrasound is available everywhere now. So there is no need for hormonal profile. There is no need for, if there is no high risk for breast cancer or anything, then there is no need for even mammogram. But if she has any problem, basic ultrasound can be done, and the basic test related to the medical conditions and the endometrial lining is important. As I said, the monitoring is a great issue in rural women. So be careful that they are coming. If you are prescribing the hormone therapy, they should come within 6 to 8 weeks, then 6 months, then 1 year. So that is very, very important. Follow-up is much more important because most of the women, they get this, they get relief. Either they are lost to follow-up or they are happy and they just continue, which shouldn't be the case.
Right. Another question is already been answered. Which progesterone? Dr. Avantika asked, and it is natural micronized progesterone, which is added to MEMUP as the progesterone in it. Dr. Ruchita Agarwal is asking you to kindly repeat the regime, whether it is cyclic or continuous, ma'am.
Yeah. This one is you can continue. This is a continuous one. So those who are having established menopause, they can be given continuously because it has a full protection of progesterone and it has full effective dose of estrogen, which will relieve her menopausal symptoms, and it will helpful for the primary prevention of osteoporosis also.
Right. Dr. Asna Ashraf, she thanks you for a very comprehensive talk, and her question is, in a patient with surgical POI who has not received high hormone therapy for 3 to 4 years because nobody started it, when do you want to initiate hormone therapy? And will you start at a standard high dose or start with a low dose and then increase gradually to high dose?
Yeah, as I said in my lecture itself, that in POI, the hormonal profile has to be done, which is the basic need. And we see the hormonal status, and accordingly, we can regulate the doses. But there is no point in wasting time because already she has lost a lot, her quality of life, her bone loss, and everything. So whenever you see a patient of POI till the age of natural menopause, you should continue to give and monitor and titrate the dose accordingly, according to the relief and other investigations which you are regularly doing during follow-ups, as I have already mentioned in the algorithm. And I would again say that keep a copy of these algorithms on your table and remind yourself that when to call the patient, what to do when they are coming, and have a checklist.
Another, again, the same question, which progesterone? So MEMUP contains natural micronized progesterone. Okay. Neha Jain, can we prescribe HRT prophylactically in TAH with BSO patient near age group of 40? What type of HRT?
This case is very simple, you know, already surgical menopause, there is no uterus, so you can prescribe whatever type of MHT if according to her choice, according to the availability, according to her medical status. If she is healthy, everything, you can go for this combined for only estrogen, not this combined one. So we have available only estrogen preparations. But I would say that in my clinical experience, only alone estrogen will not help. It will help for vasomotor symptoms, but for other problems like sexual difficulties and all those things, I think Tibolone is a better salt for gonadotrophic properties.
Dr. Anju Gupta, how do you go about if you have to increase estrogen dose from Aligarh?
If you are prescribing for POI, you already know the hormonal levels and you know that patient is suffering from vasomotor symptoms. And if you want bone protection, it has to be a standard effective dose. And in POI, we can increase the dose. But if the VMS is controlled and the patient is, closely monitored also, then we can start with the smallest dose, and then if not controlled, then you can increase. So it depends on your monitoring, it depends on the patient's response, and it depends upon her pre-hormonal, pre-MHT status.
How long can it be given safely, Dr. Rashmi Agarwal?
I have already sat for 5 years very safely, within 10 years of menopause very safely, and before 60 years of age very safely.
Again, the question is cyclic or continuous. MEMUP is a continuous therapy.
MEMUP is a continuous one. So continuous we prescribe where the patient is menopausal and having uterus. Very simple.
Dr. Shaila Jamal wants to know any studies with DHEAs?
Yeah, there are studies with DHEA, and you can go to the global consensus statement, various meta-analysis and all these reports are there, and you can see there. And but in my clinical practice, for me, I am prescribing oral DHEA only for short term in 3 months. and the indications I was already told. Any more questions?
Yeah, Dr. Ruchita Agarwal, if a patient comes up with vasomotor symptoms for the first time, what should be the first line? Premarin tablet or Memap?
I would say if the uterus is intact, to be on the safer side, alone Premarin will not help. Because we have to add progesterone, then you will search another progesterone, and then you will add, and then the convenience of the dose and the convenience of the patient as a single formulation is always referred by the patient and for us also. So it is good to have control with continuous combined if the patient doesn't need any periods or if she has uterus intact. It will be controlled. Of course, if the patient is of a surgical menopause, then you have to titrate the dose. You can start with minimal dose of conjugated equine estrogens or estradiol preparations, and then you can increase also. In POI patients, sometimes we have to give high doses of estrogens, but it has to be closely monitored and the risk benefit ratio has to be identified.
Right. Dr. Avantika Sharma wants to know Memap only for vasomotor symptoms? Does contain progesterone, so the sleep quality improves.
Yeah, because I will share one thing to all those attendees, that there is a syndrome which is called as it's a syndrome which is like with sleep, disturbed sleep, then vasomotor symptoms. Then again, because of vasomotor symptoms, she cannot be in daytime. The quality of life is decreased, and there is depression. So it is a psychosomatic disorder, which is the patient is alone is trapped. So once you treat the menopause symptoms, the cycle breaks and the quality of life improves. So it is very, very important to look up to this. So, and as I said, vasomotor symptoms is internationally, recognized, and guidelines are given. This is the VMS is the most important indication of prescribing MHT. Hello.
Rural settings. Is
Hello.
Tibolon a drug of choice in rural settings?
I think it is much better because Tibolon does not need much monitoring, and it is again a single dose. But again, the baseline checkup has to be done because we have a limitation. If the endometrial thickness is only less than 5 millimeter, then only around 3 to 4 millimeter, then only you prescribe, and you cannot prescribe an early menopause. Means initial
Perimenopausal.
initiation of menopause.
Perimenopausal stage.
So that is very important.
Okay. There's a question that MHT can be prescribed in perimenopausal patients with VMS?
Yes, why not? We should. I have already given the indications like POI and early menopause and perimenopause. Because the hormonal fluctuations are making, the life of a women, because of the vasomotor symptoms, sleep difficulties, even urinary problems may arise, sexual difficulties may arise. So they start facing problems during perimenopause itself.
So there it would not be continuous.
Yeah, of course. There it has to be continuous.
Do we start directly with hormones in VMS, or can we start with non-hormonal first?
It depends on the patient preference. As I have given you the 5 important things: patient preference, availability, the hormonal status, associated conditions, and the status of uterus or not. So if you are giving estrogen. And if it is indicated, better to go the estrogen therapy, means combined one, if the uterus is intact, or if surgical menopause alone estrogen, because there is significant relief in vasomotor symptoms. But if estrogen is contraindicated, then you can go for the hormonal preparations. And if the patient doesn't want to have MHT, then of course we have no choice. We have to give non-hormonal preparations.
There's a list of so many questions coming up. And it's been a very good interactive session, but we have to close by 4:30 and it's already past the time. But we'll take up 2-3 questions more, ma'am, if you permit.
Yeah, please.
Okay, so what if there is a family history of breast cancer? Dr. Mohini has asked. And related question is if there is any history of endometrial cancer in family, can combined E plus P given for 3 to 4 years post-menopausal women?
I think this is a little bit tricky, and if means there is no contraindication, but for breast cancers we have to have markers at hand before, we have to have mammograms, and we have to explain the patient, and depends on the benefit and risk equation we have to prescribe. But patient, those who have risk reduction surgeries or all those things, we cannot prescribe.
Another question related is there any correlation of MHT with treated CA thyroid patient?
I'm sorry, I don't have any data related to that, but I think the thyroid status should not affect the menopausal status. And I think this is a question of a specialist. I'm sorry, I cannot give you the right perfect answer, but I think it is not contraindicated. This is a question to me myself. I need to learn. Thank you.
So, ma'am, now we conclude with the question answer session, because as it is, if we keep going on, it will be another half an hour. So we now need to choose the first 3 best questions. If you would like to point out any one of those. There was one which talked about rural settings with limited
I think
resources.
this was the number one. I like
This is the number one question which you said you liked it. Dr. Sanjana Bhatt, one of the that is the one winner that we have. The other question was Ashna Ashraf POI, time has been wasted and all.
Yeah, I think that is also a very practical and clinical relevant question, which we are facing. So it is worth to remind ourselves that we should not waste time.
Okay, and then the third one would be Premarin or Memap, Dr. Ruchita Agarwal. What do you say, ma'am?
Yeah, fine. I think there is no comparison. I don't think this question is very relevant. Okay. And we should choose another one, because there is no comparison, because Premarin is having only estrogen and Memap is having combined one. Right. So they are not equal. So we cannot compare the efficacy.
There were 2-3 more that I have noted down. You can choose. I'll speak out the 3 other ones. There is one which was talking about studies with DHEA. There was one which is
I think this was a very relevant question, because we are prescribing,
so
and
the third winner is
we should have Indian scenario studies, and it's a thought-provoking question. And I think I have also taken a note of it. I think we should have, even in my group of cases, I will try to collect the data. So congratulations for wonderful questions. And
all the 3 winners, that is Dr. Sanjana Bhatt, Dr. Asna Ashraf, Dr. Sheila Jamal. I would request you to please post your phone number, could be posted into my phone number which was displayed, putting it down again in the chat box so that we can be in touch with you. Dr. Sanjana Bhatt, Dr. Ashna Ashraf, and Dr. Sheila Jamal. So you have been promoted to this side, to the faculty side, and you can put on your video and we can all see you also. Congratulations.
Yeah, I would like to see. I would like to see all the winners.
Dr. Shaila Jamal is from Bareilly. Hello,
Small
ma'am.
Delhi.
Congratulations. Thank you so much
Thank you.
for this interactive session that we had. It was really wonderful. Dr. Neha Jain and Dr. Sanjana Bhatt, if we can have your videos on, please. No, sorry. Dr. Asna Ashraf and Dr. Sanjana Bhatt. Hello, Dr. Asna Ashraf. So, if we could have you unmute yourself. Yeah.
Hello, ma'am. Good evening.
So, you are from which city, ma'am?
I'm from Lucknow.
From Lucknow. And,
Congratulations, Dr. Asna.
Thank you, ma'am. Thank you.
and if we could have your, number in my phone.
Yes, sure.
Right. Thank you. Dr. Sanjana Bhatt, hello. And unmute,
How are
please.
you?
Yes, ma'am.
Congratulations, Sanjana.
Thank you, ma'am. Thank you so much. It was a wonderful lecture. I learned so many things. I'll be in touch with you, ma'am.
And
Sure.
you are
Most
from
welcome.
which city, ma'am?
I'm in BITS Pilani, ma'am. I'm working in BITS Pilani. So
Okay.
you'll have a lot of patients from BITS Pilani, ma'am.
Right. Thank you so much. And I'll require your number into my right.
Yeah, I did send that to you.
Okay. Right. Thank you all so very much. And it was a pleasure to have everyone, interact so very well. Now we move on. And
Thank you for an excellent lecture, ma'am.
Thank you so much.
And now we move on and remind you that there is a public awareness session that we conduct regularly, and the next one is going to come up tomorrow. This is a public awareness webinar, and what better than having Dr. Nozar Sherrier, the author of the book, which is Finding Your Balance, your 360 Guide to Perimenopause and Beyond. You can make a note of this and join in yourself, or ask your friends and family to join in, and ask your patients as well to watch the previous recordings of these public awareness programs. You can click on our mysakhi.in events, or you can also register for this webinar through that link, mysakhi.in/events. MySakhi.in is a CSR initiative of Jagsonpal. Do join our public awareness programs also, and motivate your patients to join in for live interactions with experts who join us. Jagsonpal is committed to women's health, science, and service.
So,
You can scan this.
thank you.
You can scan this QR code and reach the website mysakhi.in. The recording of this webinar is going to be available. The recording of this webinar is going to be available on Facebook. Also, it will come up on our YouTube channel of Jagsonpal Medical Insights. So you can refer to the same lecture again and again. And we thank all the delegates for joining in today. Look forward to having you again and again into our webinars. And thank you so very much, Dr. Sunila Khandelwal, ma'am, for such an interesting and informative webinar today.
Thank you, Deepika, and thanks for all the attendees for making this session very interactive and very interesting. Thank you so much for your interest and for in this menopausal field of complex medicine. Thank you.